Welcome to Connect to Develop, where we provide insight from healthcare leaders on the hottest topic and trends.
Hello, listeners, and welcome back to another episode of Connect to Develop. Today, Marney and I are thrilled to be joined by market access expert Janet Poppe as we dive into inside market access, expert insights, and best practices. Janet is a seasoned expert in market access strategy with over 30 years of experience working across health plans, employer groups, provider networks, and government agencies. She's led team focused on reimbursement, payer relations, and strategic partnerships. Janet, we are so excited to have you joining us.
Thank you. Yeah, thank you for having me.
Before we dive into strategy, trends, and really the meat, I would love to hear a little bit about your background and your journey. Can you tell us what first sparked your interest in market access and reimbursement, and really what drew you into this space?
Well, that's kind of an interesting story. It wasn't on purpose. And it's funny how our careers go like that. I mean, look at you two doing a podcast. Maybe you never thought you'd do that. But I started in 1990. So I'm dating myself as a pharmaceutical rep for a large pharmaceutical company. And I was very excited. They sent us back for weeks and weeks of training on the products, and we learned all the studies and role played on how to present these to doctors. And I came back to Phoenix and I was so excited. And I went in and I started talking to doctors. And one of the first doctors I presented to, he slapped the brochure down out of my hand onto the desk and said, "Is it on Cigna?" And I said, "I'll find out," because I really didn't know. So you got to remember back in those times, most of the doctors, most of the insurance plans were kind of 80-20 fee for service. So you would have maybe a Blue Cross Blue Shield plan or something, but and a lot of the doctors didn't even bill insurance. You would just pay the doctor and you would bill the insurance and you would pay 20% and they'd pay 80%. But back in those days, several of the markets like Phoenix, LA, Boston, managed care organizations started coming in and the doctors started signing up with them. And so this company I worked for realized all of a sudden, oh my gosh, in order for us to sell in these markets, we're going to have to understand managed care and start working with these payers. So they created 8 new roles called regional account specialists. And my manager said, "I really think you should consider taking one of these roles." And I just took the risk. And 35 years later, here I am still learning.
That's so crazy. It's so true. You just never know what, directionally how things are going to pan out. So I guess to help set the stage for Marney and I, as well as our listeners, can you help just define market access for us? What's the high level definition of market access and reimbursement, and why is it such a critical part of today's healthcare landscape?
Yeah, that's a really good question. The simple definition, I guess, would be making sure that patients have access to medications or devices that their providers deem necessary for their care. But it's much more complicated. How do you do that? How do you make sure that the patients have access, that the providers are able to offer them, and that they're at a price where the providers and the patients can afford to use them? So it really is 3 things. There's coding, coverage, and reimbursement. And all of those need to happen in the way that we're set up now in healthcare. So coding, there are CPT codes for procedures and then HCPCS codes, which are more for products. And once you have a code, then you have to make sure that code is considered covered or that it can be billed and used underneath that health plan. And you remember all of these different health plans. When you've seen one health plan, you've seen one health plan. So they're all different, but they usually have a formulary or a medical policy, and you have to have your product considered covered with studies, et cetera. And then coverage doesn't necessarily equal reimbursement. So then you have to look at is reimbursement tied, is payment associated with this coverage? And is there a professional fee for the doctor or a product reimbursement fee? So all of those things have to happen. And to sort of the second part of your question, why is this so critical in today's healthcare landscape? Well, first of all, if your product doesn't have coding, coverage, and reimbursement, it's probably not going to be used. The doctors won't be able to offer it. The patients don't have access to it. But it's also complicated by the fact that kind of when I started, remember I said that there wasn't a lot of managed care and it was more 80-20. But what's happened over the last probably 10 or 20 years is there's been a great consolidation of health plan payers. So you've got really the big five that are kind of the big national insurers, United, Anthem, Aetna, Cigna, Humana. And then you've got your state blues plans. And what's happened over time is that the doctors have become very dependent on those commercial payers for the patients, for the lives that they serve. So they have to follow the rules of those payers because they can't afford to be kicked off of the provider network. So it's created a lot of consolidation. That's why you see a lot of the providers ending up in big, large group practices or even being employed by hospitals because it's complicated to get all of this done. So it's important, but in order for them to have what they need for their patients, they really have to get involved and they have to understand how to make sure that there is access for their patients.
Thank you for that, Janet. We keep hearing about the declining reimbursement rates. It's just a theme, just in healthcare across, I think, all arenas. You keep hearing about declining reimbursement. And as we in the healthcare field really help support surgeons, regardless of the role that we sit in, how do they remain educated? What are some opportunities where they can continue to remain educated around how the payer landscape has evolved or changed really year to year, right? CMS is always putting out new rules. Would love to kind of get your thoughts on, what are some educational ways that surgeons can remain informed?
Mm-hmm. Yeah, I feel for these providers. My son is a young doctor, so he's a doctor, but he's finishing his residency, and they're not really trained on any of this stuff. They're trained for inpatient care, and that's what they really want to do is take care of the patients. But they really need to understand how to navigate all this. So some suggestions, I would say there is strength in numbers. So if you can work with your society and the society can support its members or a lot of them are in larger groups where they can employ somebody that can be researching all of this and understand all of the changes happening, how to navigate it, how to bill. All of those things are really important. And sometimes there are even misaligned incentives. Like if a doctor does a surgery in the outpatient setting, it might be better for the doctor, better for the patient, but they may be reimbursed less. And so that could force things back into a hospital setting, which isn't great for everybody. So there are a lot of things that they really need to understand and support. I would also say they could check into a billing company or a revenue cycle management company that might be able to help them to make sure they're not missing any billing that they could be billing, because it is very complicated. But I will say that in the last few years, I've seen some pushback where some of the providers are actually moving to concierge care, where they just are deciding to limit the amount of insurance patients they take with insurance. Some are taking no insurance and it's just fee for service. And I was thinking about it, and most of us, I know I'm on a high deductible plan. So I'm kind of have catastrophic care and then I'm paying the rest myself anyway. So I think we may be going back to where we were at the beginning in some ways. You've got Mayo and other large hospital systems now that aren't even decided they're not taking Medicare Advantage, that are managed by commercial payers. So we'll see what happens in the future. But I think that doctors really have to set themselves up well with the resources that they need to understand what's happening and make sure they're not losing any money they could be making in billing.
What about from the angle of negotiations? I know there's all these platforms where surgeons can find ways to get educated. You mentioned the societies. How do they lead from the angle of being able to be an advocate in negotiations? What does that look like? Like, what kind of seat at the table do they need to have? I guess I'm not really familiar with the negotiation piece of it, but I would imagine that they have a level of negotiation authority as well. Any insight or thought?
Yeah, definitely. And that's kind of what I meant by strength in numbers too. If you're in a market where you are in a large group practice that does orthopedics and that payer needs your services because you are the big orthopedic group in the market, you have a lot of leverage because they have members that need to have care in that market. So that's where I think we've seen more of these large groups and hospitals employing physicians because they're all trying to get leverage to get more on an even playing field with some of the health plans and payers. But I would say, working with the societies is probably one of the best things they can do. A lot of these societies have committees that are specific to negotiating payment for different procedures, different codes, et cetera. So I think they just need to look into ways they can get involved in their societies. It's probably a great way to start.
I love all of that. I've been a little bit quiet because probably very similar to many of our listeners, I'm really learning about this topic and absorbing it. So this is incredible insight, but let's unpack this a little bit more if we could in, almost a case study example. Societies are incredible. I know that AUKUS has an amazing advocacy team that's on a very regular basis going and championing the overall hip and knee arthroplasty community on the Hill. But let's be honest, it takes a while for things to change. And in today's administration, we really don't know what's going to happen for the next few years with that. So back to the point that you made with, advocating for a local payer if you have a decent enough scale. Let's say that I'm in a, 15 to 20 surgeon provider. So overall, we're probably looking at about, 100 employees. There's probably 15 to 20 surgeons, maybe, 15 to 30 mid-levels, so a decent, amount of coverage. How could I approach a local payer to advocate for, our group, and what kind of data am I bringing? And then also, and I remembered this back when I watched a few managed care talks that the previous company I worked for that was in the ambulatory surgery space gave to some orthopedic conferences. Who at that payer group, because I think doctors always think they just get a hold of the medical director, but really who is going to make those decisions and work with that group for better rates or however that works?
Yeah, that's a great question. So I do suggest that they find out who the medical directors are for their dominant payer, and not just the medical directors, but a medical director in their specialty that understands their specialty, which is really important. But then there are a lot of other people that they can contact at a payer. So there's somebody that's responsible for provider relations, and that they could certainly talk to those people because that's their job. And then I would say, they should talk to, it depends on what they're trying to do. If they need to get a policy change, there's somebody that's head of policy. So it kind of depends on what they're trying to do there. But the health plans, the customer of the health plans is the employers. So this is something I think that a lot of doctors don't understand or forget. Most of the large employers, if it's over 5,000 lives, they are self-funded, self-insured. So the health plans are doing administrative services for them, but the decisions are still, the benefit decisions are being made by the employer. So I have had some doctors group, a group like you're talking about, go to a large employer near them that is a customer of one of their payers and talk to them and come into their facility, do some education, talk to the employer themselves. And then together they go to the payer and say, hey, this is something we want to cover. We want to be able to send our employees to this organization, to this group. So there are a lot of different ways that you can approach it. You really need to figure out where your leverage is and how you can partner with the payer. But if you can make the payer look good in front of the employer by bringing better care, that is always what you want to do. So data is king. If they have good data, they collect their data, they show good outcomes, they show that they're saving money, but also providing good outcomes for the patients, then chances are the health plan is going to want them in the network and to be able to support whatever it is they need for patient care.
Sounds like data is king, but if you don't know what to do with it, how to present it, and whom to present it to, that's even the bigger piece of the puzzle.
Yeah, that's true. And that's kind of part of what I do as a consultant because I've done it for so long. Every payer is different. So you really kind of have to do your research and figure out where the decisions are made for whatever it is you're trying to get done, and then how to get to those people and make sure you have an audience with the right folks and then present it in the right format.
That's all incredibly helpful. This is a complex topic, which is exactly why we wanted to unpack it, because it's a theme that's continuing to come up. We've talked about providers and surgeons, how they can leverage. How about from the pharmaceutical and device side? So much of what you've done over the majority of your career, Janet, is educating, building teams in that arena because of the need to be able to leverage the information to create access for patients as well as support surgeons. So from that angle, how can pharmaceutical companies how do they navigate the complex reimbursement environment, to really be able to drive those innovative therapies and medical technologies forward?
Yeah, so I guess one thing I'll say in just defense of the insurance industry is that what we've also seen over the last 10 or 20 years is these pharma and device companies have developed some very, very expensive medications and devices, implants, et cetera. So there really is a need to manage the costs and make sure that care is affordable and it's appropriate care. So that's where we lead to managed care. And I would say, to answer your question, every situation is really different. So if you've got an innovative therapy or technology, the first thing that I do is do a landscape assessment of the market and the competitors so that you can really understand what are the current codes that are available? Are they appropriate for my technology? What are the current reimbursement rates? Is there enough reimbursement under a code that I could already use for my product? And if that's the case, you may just want to stay under the radar. That's why it's important that you know what you're stepping into. Before you go to payers, maybe you need to get some more experience in the market and gather some data, get some key opinion leaders to use your product, put your value story together. And if you already have a code that's giving you reimbursement, then you may want to use it. If that's not the case and there's not sufficient reimbursement under an existing code, well, then, you've got a couple of different options. One, you could try to get a breakthrough designation status from CMS if your technology really is considered breakthrough. And then you could apply for what's called NTAP. It's a new technology add-on payment in the inpatient setting. So, in the inpatient setting, these procedures are paid under a DRG. So it's just one lump sum of money they get for the procedure. But if it's considered in your NTAP application that there's not going to be sufficient money in that one lump sum of money where they would actually use your new technology because it doesn't cover it, then they'll give an add-on payment. So that's a possibility. It has to be a new product, so within 2 to 3 years of it being brand new. Because then what Medicare does is, their data runs delays for a couple of years. So what happens then is they go back a couple of years after you've had this NTAP additional payment, and they'll take a look to see, was it appropriate? How much was it actually used? Do we need to make this permanent? How, is there enough money underneath what's current so we don't have to continue this add-on payment? They'll take a look at that. Or in the outpatient setting, there's something called a pass-through payment, where you could then get a pass-through payment for the first couple of years for the same reason. So Medicare could look at your new technology and see what permanent payment there could or should be. So those are a couple opportunities. I would say a couple of things. Like I said before, data is king. So one advice I would give to a company is get involved early with your clinical teams and make sure that the studies include the things that the payers are going to want to see. So they should have, for instance, a comparison to what is currently the standard of care, not just is it safe and effective. If you could put in the study something about the actual value, the outcomes of it, maybe it can replace something that the payer is currently paying for. Those are all things that if you set it up correctly at the beginning, you'll be more successful with your payers. I have been at companies where the clinical folks that are doing the studies never talk to the commercial folks. And when the study comes out, we look at it and think, we can't use this. So it's really important to get involved early. One other thing I'll say is know your stakeholders. So Erika, I know you know this from our past experience, but there are a lot of people that might be advocacy groups that would support your product or your device. Maybe there are other non-competing companies where you have a mutual interest where you could work together and, advocate for your product. So make sure you know your stakeholders, and then, data is king.
That's all really good feedback. Now, you mentioned data is king, but I would also say that data is king plus awareness and education. Just organizations need to have a dedicated force to be able to how to navigate and advocate and work with, partner with surgeons, both on the pharmaceutical device side, but then on the provider, hospital office side, just having really solid billing and coding team members, as well as folks in place that can help they know this landscape, they know how to navigate on behalf of whether it's hospital system that they serve or company, pharmaceutical device company that they work for. So that's all really, really good feedback. What are your thoughts on the shift towards value-based care models? How is that impacting most of, I guess, just the reimbursement landscape? And I know there's some dynamics here, kind of working in the quality space. We've talked about that in the past, but what are your thoughts with the value-based care shift?
I think it seems like a really good idea, and it has been successful in some places, but the devil is in the details with this. So for it to be effective, it really has to be a partnership between the doctors and the providers, maybe the hospitals, and the payers. And all of that partnership between the three has to be with the intent of the best care for the patient in mind. But if it's lopsided and it's benefiting the payers and not the doctors or the provider organization like the hospital, it's out of whack. So I'll give you an example that this is from a long time ago, before value-based care, I'm doing air quotes, came into being. But I was at a very large hospital system, and I was listening to the chief medical officer present, and he was explaining a dilemma that they had a lot of births of preemie babies at this hospital system. And what they would do if the baby's lungs weren't developed enough, they would intubate the baby. They would transport them to one of their facilities that was expert in, preemies, and to make sure that the baby's lungs developed and they were safe. But along the way, I think it was a group of nurses, I can't even remember, but that they figured out, they said, why can't we just try a sleep apnea machine on these babies and see if that keeps them breathing and helps them have time for their lungs to develop? And they tried it and it worked great. So great value, better for the patient, better for the payer, not better for the hospital, because the hospital was able to bill for the intubation. They were able to bill for the transportation. So it was going to be millions and millions of dollars that they wouldn't bill anymore. Well, this is a really great facility, so that wasn't an option for them. They were definitely going to do the right thing. But what they did do is they contacted their major payer partner and said, hey, we figured this out and it's much better for the patient. It's much higher value, but you're the one that's going to be saving the millions and millions of dollars, and we don't get the millions and millions of dollars. So they worked out a deal where they shared in the savings. So that's a win-win-win. And that's the kind of case you have to find where you have.
That's incredible. And I love that they were able to find a payer and a true partner that was willing to say, you know what, you're right. We will change this and make sure that you aren't out millions and millions of dollars for actually doing the right thing. So I absolutely love that. I want to ask a very relevant question to where we are in massive group aggregation and entities, like the Optums of the world and the ChenMeds, et cetera, who are taking risk and kind of winning that way. we see a lot of these private practice groups aggregating and forming super groups. And mostly what they do it is for economies of scale, make the cost of doing business cheaper, get better rates, etc. And yet they haven't successfully done that. Where do you think that some of those groups could be tightening down and utilizing their data better? Or where do you think, it's going wrong? Because most of the people in super groups that I go, hey, how's it going? You're getting better rates, getting lower cost of supplies. They say, no, actually, that's not going well.
Yeah, that's a tough one. I don't know that I have the answer to that. I think we're going to see a lot of change over my career. I've seen these things like these super groups build up and then break down and build up and break down for that very reason. I think it adds a lot of complexity. They're trying to do it to have leverage, but also, like you said, shared services. But then there's something lost in the quality and the, time you could spend with patients and all the other things that, got them into healthcare in the first place. So I don't really know the answer to that. I think it's something we're just going to have to wait and see. So I don't know, to be continued.
Probably a lot to be continued with the complexities and just the changing landscape. I think the one thing that's a common denominator is that healthcare every year and its dynamics just looks different than the prior year. So this is definitely an area that will continue to evolve. Now, Janet, I personally have been, super lucky to learn from you, be mentored by you both professionally and personally. You've taught me so much, just professionally and in this space specifically. If you could leave our listeners with one piece of advice, whether they're just stepping into market access or already leading it, what's one thing that you would want them remembering? And then a second add-on, what are the greatest leadership lessons that have been most valuable in your career?
Okay, well, the first part, I would say, whether they've been in market access a long time or they're stepping into it, market access, we used to call it managed care. Now it's called market access. But it's a small community. It's a very complicated, difficult thing to learn. Like I said, I've been doing it 35 years. I'm still learning because it is ever changing. So you're never going to be able to know everything. But what you can do is build a network, experts or people that know different areas of market access that you can be able to reach out to. So I think that's one of the things that's made me successful over all these years. If I don't know, I know somebody who knows. So number one, know all of your products, your own products inside and out, but know the people in your network that you can reach out to for the things you need. And the second part of your question, just about kind of leadership lessons, maybe the very most important one is hire the right people. It seems simple, but if you spend the time really making sure that anybody you bring into your team, your organization, is the right fit and the right person, then you spend the time up front. You won't spend the time managing them on the back end, which takes all the joy out of work. So make sure you hire the right people. And the other thing that I would say, I know, Erika, you've heard me say this, and all the people that have ever reported to me over the years hear me talk about focus. So I would say if you can keep your focus set on maybe the top 3 things that will have the biggest impact, and then wrestle those things to the ground and finish them. Because what ends up happening a lot of times is departments will get an inch deep and a mile wide doing a whole bunch of different things, but they never really finish something so that it's a deliverable that they can use, they can show, that will take them to the next level, that they can scale. Maybe it's a project that they do that then goes well. It's a case study and they can scale it once they finish it to the rest of the nation. So I would say hire the right people, stay focused and finish what you start. Don't be afraid to try new things. Even throughout my career, that first job, I started as a sales rep, but that first job didn't exist before I got it. And all the jobs I've had in my career, I think only 2 of them really existed before I got the job because they were new. So I'm used to, I call it sculpting fog, but I'm used to sort of, being able to assess something and, start up a new division. Don't be afraid to do that. Build alliances, mentors inside and outside your company, and just be resourceful and use all the resources you have available to you in your decision making.
That's all excellent feedback. And I remember very, very, very well. And I still use that today, Janet, the focus component, focus it and wrestle it to the ground. It has served me well. Well, this has been great and super informative. I really, on behalf of Marney and I just want to thank you for being on and sharing your experience. It's been an absolute pleasure.
Oh, thank you so much for having me. It was fun.
If you want to learn more about Janet, please check out her bio in the show notes.
You can find more interviews on our YouTube channel at Marney Reid Presents.